This is Just Say HIE, the official podcast of the Hope for HIE Foundation. I'm Betsy Pilon, your host, bringing the stories of the HIE community from around the world to you, our listeners. Hope for HIE is a nonprofit organization and the largest collective of HIE families anywhere in the world, and each story across all outcomes has its own version of hope to share. Join us as we explore each unique journey and connection.
All right, we are recording. Welcome, everyone. It's officially HIE Awareness Month, and we are talking today with two members of our medical advisory board, and we're talking HIE and seizures, which tends to be one of the top topics in our community because our, families and children, many of them experience neonatal seizures at the onset of HIE, and we know what a significant burden it can be in our community. So I'm excited to welcome Dr. Renee Shellhaas and Dr. Hannah Glass today to talk about this important topic and all of the incredible research that they partake in and that we have worked together in a little bit and kind of walk through, the impact of this on our community. So Renee, if you want to, give a little quick introduction about you.
Thanks, Betsy, for inviting us. I'm Renee Shellhaas. I am a pediatric epilepsy specialist at the University of Michigan, and I work with Dr. Glass to co-lead the Neonatal Seizure Registry, which is an organization of 9 pediatric hospitals across the United States that specialize in neonatal seizures and their follow-up. So Dr. Glass and I have been working together for 5 or 6 years now on this topic, and we're really excited to be here and to share information for you.
Great. And Dr. Glass.
Hi, everyone. My name is Hannah Glass. I'm a professor of neurology and pediatrics at the University of California, San Francisco. And I study outcomes after early brain injuries, including hypoxic ischemic encephalopathy. And Dr. Shellhaas gave a great introduction to our work with the Neonatal Seizure Registry, and looking forward to sharing some of that with you guys today.
Wonderful. Thank you both. So we'll just dive right in. Can we talk a little bit about just starting at the beginning of HIE and seizures and, a little bit more about starting point of, what about the injury triggers seizures?
Yeah, so I think most of you know that hypoxic ischemic encephalopathy really means that there's been some episode of a lack of blood and oxygen to the brain. And our brain cells, called neurons, really need that energy to survive. So if ever there's a period lasting, several minutes or more, the brain cells lacking that energy can start to die. And that can set off a cascade of events where more and more neurons or brain cells undergo changes and can ultimately die. And it's when these neurons are impaired in their function that they can start firing together in a coordinated way, and that's what manifests as a seizure.
Very, very helpful to understand that, and especially with that cascade as we, learn about what that does, to the system. So, neonatal seizures, obviously, seizures are not good. So can you talk through a little bit about, treating them in the NICU, onset, and, why these frontline medications are used and important, and why it's important to, use them for a period of time, and, kind of talk through what, about, how they can be controlled, and then, kind of that medication. Some people, obviously, no one wants to have their child on, heavy hitting anticonvulsants. It's not a fun thing. HIE is, a very traumatic time for families. But we know that it's very important, obviously, to control them. So can you talk a little bit more about the science behind that and kind of what the frontline medications and efficacy is with that?
Sure. So I think two really important things about seizures, and probably the most important thing is when a newborn is having seizures, there's a sign that something's happened to the brain. And in the setting of HIE, it's a worry that there has been brain injury as a result of the hypoxic ischemic insult. And as a community, we feel that treating the seizures as fast as possible really gives the child the best chance, first of all, to stop the seizures. And second of all, there is some concern that lots of ongoing seizures can compound the injury that's happened. And our information for that is mostly from animal studies. It can be really hard to know for sure in children. But as a community, we feel like we all think it's the right thing to do to treat the seizures. And knowing that we're going to treat them, our goal is really to treat them as fast as possible to get the best chance of good control. Dr. Shellhaas and I have done a few studies, as have lots of great investigators around the world. And phenobarbital is really the number one choice for stopping seizures in babies. It's, not our favorite medicine in the world because it does cause the babies to be sleepy and can take a while for it to clear from the system. But on the other hand, it works pretty well. Probably about between a third and a half of children will respond just to that one first loading dose. And then another half to 2/3 will require either more loading doses or additional medicines. And I think that some important information that we've learned studying kids over the last few years is that really that medicine doesn't need to be maintained long-term. So historically, kids could stay on phenobarbital for maybe 3 months or 6 months or even a year. And our newer data suggests that it's safe to stop that medicine after those acute seizures have resolved.
Yeah, I think with the HIE community, it's going on 9 years now, almost 9 years, and seeing the evolution of, this, especially for new families that join and ask questions about, their child being on phenobarb and things like that. It's always, when can we get them off? Is it safe to do so? And, it's been really amazing to see because I think, standard of care, then was definitely 3 to 6 months and then looking at weaning. And it's just amazing to hear that some kids, can come off earlier, which I know, again, to the point of, if it's appropriate, it's obviously beneficial to control those seizures. But if, a child can come off of it, it's always, nice to be able to have that and have them, so many parents express when their kids, do get weaned off, it kind of wakes them up a little bit because it can be so sedative. So they're sedating.
Yeah, I think one of the other things that we get a lot of questions about is how do I know that the baby's having seizures? Mm-hmm. And babies do all kinds of funny movements that aren't seizures. And then they have seizures and sometimes you're looking at the baby and you can't tell. And so one of the things that we've been working really hard on is being really precise when we're doing research to decide if it's safe to use a medicine or to take a medicine away, to use the EEG. And that measures brainwaves and it shows us patterns that tell us about seizures. And so if a baby has a funny movement and their EEG is running and there's no change on the EEG, it's not a seizure. It doesn't need to be treated with anti-seizure medicines. On the other hand, babies can have seizures without having unusual movements. And if you think about different areas of the brain control different parts of what a child is doing, and if the area of the brain that controls movement is not involved in the seizure, then the baby won't necessarily move. And so sometimes it's really tricky to tell. And that's why we use the EEG monitoring so often in babies with HIE, because we know that they have a high risk of having seizures in the newborn period. And we want to be very clear when there are seizures and when there are not, so that we can treat a baby who needs medicine and not treat a baby who doesn't need medicine. So I think that's an important distinction that families need to hear about.
Definitely. That's so critical when really just, you're thrown into this very unusual situation. It's scary. seizures are scary and, the unknown of what to look for and be educated on what to look for. We talk about that a lot after discharge and just having like this awareness of, what to do and being proactive. We'll get to that a little bit more about, building these relationships post-discharge. But, really kind of want to talk a little bit more about, what are some of the specific seizure types that are more prevalent in HIE that might develop out of the NICU or in childhood? Because I know, epilepsy is so complex and there are so many types of epilepsy out there.
Sure. So I think the first thing is you'll notice that Dr. Glass was talking about the symptomatic seizures. So there are seizures that babies with HIE have right in the first couple of days of life. And those are what we call acute symptomatic or provoked seizures that are a reflection of the brain injury that happened with the hypoxic ischemic event. That's different from epilepsy, right? So epilepsy is a tendency to have recurrent seizures without any additional injury or a provoking factor. And so most of the babies that we look after who have HIE and may have seizures in the newborn period actually won't go on to have epilepsy or have any more seizures. So that's the good news. The bad news is that some of them will, and exactly how many is a little bit hard to pin down, but maybe up to about 1 in 5 babies will eventually come back to have epilepsy or repeated unprovoked seizures after the newborn period. What do those seizures look like? It depends. It depends on the extent of their brain injury. It depends on where that brain injury may be and how old the child is. So most of the time for infants who are going to have seizures, they'll have something called focal seizures. So that means that the seizure starts in one area of the brain and affects that area of the area of the body that area of the brain controls. So you might see shaking of an arm or a leg, or stiffening of an arm or a leg, or a stop in their behavior. They might stop moving or making sounds and that sort of thing in an unusual way that is repeated. So usually if a baby's going to have seizures, they'll have more than one. And typically they'll have a habitual seizure, a seizure that is their usual seizure type. And so it won't just happen one time usually. And I think that is helpful for us in distinguishing. The other kind of seizure that we want for families to know about ahead of time is something called infantile spasms. And infantile spasms are a type of seizure that is rare, but important because what we know about this kind of seizure is that the sooner we treat it, the better the child's going to do. Not that we want to ignore other kinds of seizures, but that we have specific information that if we can treat within a week or so of onset of infantile spasms and make that kind of seizure go away, that developmental outcomes are better in the long run. So what are infantile spasms? They are a seizure type that typically will happen as a baby is falling asleep or as they're waking up from sleep, that will cluster. So they'll have an event where they might reach out their arms and sort of bring their head down, or extend their arms, bring their head back very quickly, and then have a pause, and then do it again, a pause, do it again. And so they have a cluster over time. Oftentimes babies will cry in between those spasms and in a sort of unusual way, and that may also be something that parents will notice. Mm-hmm. Because they're predictable as baby falls asleep or wakes up, it's something that we listen to when we hear parents describing this kind of a seizure. It's also an opportunity, if you have the ability to make a video, to know, okay, usually it happens when they're waking up from a nap, so I'm going to make this video as baby wakes up from a nap. Having those kinds of videos as a doctor, it's extremely helpful for me to help to tease apart how worried am I about this baby.
Yeah, and we've done, Dr. Glass, I know, participated in an educational series with us a couple of years ago that we were able to record that has just been a game changer in our community because now we have all these this resource library, and our families are now, we have seen the shift from, is this something I should be concerned about, to understanding I need to record this. I need to be proactive of how to, send this to my, medical team, who I need to talk to, and, just have that awareness. And we know, like, we like to say too, like being aware of, what seizures look like, what IS looks like. It's information like CPR training. You hope you never have to know and use, or never have to use, but it's so important to know, because we know all of what you're saying and all the research that you've done, that, it is critical to get a quick diagnosis and, aggressive treatment, frontline treatment with that. And again, it's really hard. These decisions are difficult, and they're, again, you have this little baby, and it's that hard disconnect of, moving past I don't want my child on medications, to understanding that, science is there to help, help improve, development for their child, and give, the baby's brain a chance to recover and things like that.
Yeah. So I think the thing that I would just underscore there is, infantile spasms are urgent. And so if any family feels they're concerned that their baby is having infantile spasms, that should trigger a phone call, even if it's a weekend or a holiday, or a visit to an emergency department for evaluation. And sometimes it's not spasms, and, our EEG can be reassuring, our evaluation can be reassuring, and we can go on with our lives. But if it is, then they'll be glad to have shown up early.
Absolutely. Yeah. And that's definitely the consistent messaging across the board that we, are pushing. And again, it's when you hear the relief that it was caught early from our families, it really, does make a great difference. So, what other types of, epilepsy do you see in HIE? I know that IS for many kids can eventually turn into a different type of, LGS and things like that. And then there's all sorts of different types of epilepsy in general out there as well.
There are a lot of different kinds of epilepsy. The pattern that you're talking about is for babies who had infantile spasms in particular that are at risk for another kind of lifelong epilepsy called Lennox-Gastaut Syndrome. And that is, it's a very tough epilepsy syndrome. And it is a combination of different kinds of seizures. So children with Lennox-Gastaut syndrome will have convulsive seizures or generalized tonic-clonic seizures. So this kind of seizures that make them fall to the ground, stiffen, or shake. May have continued epileptic spasms. So they may get older than being an infant. So we don't call it an infantile spasm anymore, but still the same kind of spasms. And may have episodes of status epilepticus or prolonged seizures that require a rescue medication. Those children also have invariably have developmental disabilities. And so cognitive development tends to be slower, although there's a huge range of what children are able to do. And they have specific kinds of patterns of EEG abnormalities if we look at their brain waves. Why does it matter to have a Lennox-Gastaut syndrome diagnosis? I think just as you found the HIE groups, there are groups to support families who are going through Lennox-Gastaut syndrome or treatment-resistant epilepsies, and so important to find your supports there. Also that there are medications that seem to be more helpful in children with Lennox-Gastaut syndrome, or that we might be more aggressive in treating if we have that label. And to know that there are specialized centers that really can offer the cutting edge therapies that children with treatment-resistant epilepsy, or epilepsies that aren't seizures that don't go away with a medicine or two, that if you get to a point of Lennox-Gastaut syndrome as a diagnosis, or of other kinds of seizures that don't just go away, that knowing you can look for a specialized epilepsy center is really important. So is your child neurologist a pediatric epileptologist, or are you going to a level 4 or a comprehensive epilepsy center? At that point, makes a big difference.
Well, and that's definitely a piece of educational information that I don't think is widely known out there is that in child neurology, there are those specialists and those epileptologists. And, a lot of times everyone just thinks like, yeah, well, I have a child neurologist, we see a child neurologist. But perhaps, if something, is a different evolution, looking at, getting in with that, subspecialist to really target and get the kind of care that the child needs.
Absolutely.
Yeah. That's great to know. And something that, we continually try to, educate and through programs like this, hopefully people get that information to think about. And we'll share afterwards as well. There's, I know, a website that has all the list of the comprehensive epilepsy centers out there and providers, which is, I think, a great place for people to start for sure.
For sure. And I would underline that the first thing to do is to see a child neurologist, and that all child neurologists can get started taking care of children with seizures and with epilepsy. And most children with epilepsy don't necessarily have to go to a subspecialist, right. But that if your child is continuing to have seizures despite the best efforts of a good child neurologist and a couple of different medications, then it's time to look elsewhere to see are there other options that can be helpful.
Absolutely. And I think what's one of the things, and we talk about this in different circles too, is, in the era of COVID that has moved a lot of things to telehealth, it can also make access a lot better for families that, are in rural areas or, have to traditionally travel very far to see different specialists. So just looking at, what are those, resources and just being mindful that, so a lot of providers now are able to provide telehealth services a little bit more than in the past and have insurance cover those and things like that. And, continuing to advocate for the coverage moving forward as we hopefully come out of this curve of a pandemic. So
sure thing.
Yeah. All right. And then I guess I wanted to mention as well, because as we're going through this kind of child development phase, are there different developmental times? We kind of anecdotally see this in our community, but are there, from the research, like these times as we're tracking long-term outcomes, especially through, I know, the NSR project is in different phases and other, projects like that are in different phases, but kind of key ages that you see an increase in seizures in this population or different types of seizures. I know like ESES or ESES is, and I will totally not be able to pronounce and remember all of the specifics of what that is. But, the nocturnal seizure types are something that, our families, I think, are sharing more of with diagnosis. And I know that one can also be, hard to diagnose and things like that.
So you're talking about electrical status epilepticus of sleep, which is a challenging diagnosis to make, to be sure. The hint that your child might have ESES or electrical status epilepticus of sleep at first is a developmental regression. So a child who is bright and doing their thing and learning their language and all that kind of thing, and then maybe slows down and maybe isn't quite as bright or engaged, maybe isn't speaking as much. If that's the case, it's worth talking to a neurologist about, gosh, is there something else going on? Could my child have ESES? And that is a diagnosis that is made by doing an overnight EEG and looking at the brainwave pattern during sleep. The EEG during sleep in this kind of epilepsy looks like a child's having seizures all night long. Whereas if you look at the child themselves, they're just lying in their bed asleep, but they're not getting the brain connections and learning of restorative sleep because of the abnormalities in their brainwaves. And there are certain kinds of treatments that we can try to initiate to try to help that development to pick up. So it's not as much about treating individual seizures, although we still want to do that, but about treating an EEG pattern that potentially can dampen a child's development. That is a really tricky kind of epilepsy to treat. And I would suggest that's where you want to be talking with an epileptologist to try to make sure you're on the leading edge of treatment there. But most of the time, we're not talking about those really, really tricky ones, right? And so when do we see seizures start after HIE? Several months of age, typically. So typically, if a child's going to have infantile spasms between 3 or 4 months and a year old, would be when those would show up. Other kinds of seizures, the focal seizures, in our study, the sort of average onset would be somewhere around 6 or 7 months of age, as a peak. So those infant years or infant times are sort of the highest risk for seizures, and the risk goes down over time, but it doesn't go away completely, unfortunately. And so we do see kids who are school age who will come with their first seizure, for sure.
Yeah, that's really helpful to know. And like I said, anecdotally, it's interesting as we share different information. And, obviously I've shared with both of you, that my son Max had his first seizure that we ever know of this past December at almost age 9, and, just totally threw us for a loop. And that was just like, oh, wow, this, I've seen friends go through this whose kids are more mildly affected and things like that, like ages 4 and 6. And then it's like, wow, here we are. We're, part of that club, which is, it's just one of those things where, the risk, and we were told the same by your neurologist, like the risk goes down with every year, but there's still a risk. So, but at that point, there's, again, so much good support behind connecting and more, like I think you had said the garden variety. I love how you put that, the garden variety of epilepsy. So, one of the more common types, with treatments that, can be very effective. So, but definitely something that, is a more significant burden, I think, in our community, across some of those, different outcomes as well. So,
I would also just underscore that epilepsy is very common. So, 1 in 100 kids will have epilepsy, which is 5 times more common than type 1 diabetes. I mean, this is a common problem. And so if your family is affected by epilepsy, you're not by any means alone. And there are a lot of people out there to help.
And there's some great resources too. I mean, I already found so many helpful things with our local Epilepsy Foundation chapter, and, just again, the plot twists that come along the way. But, just grateful to have so much access to good information of, just things to think about, and talking about seizure action plans, and, how those things as kids grow up with epilepsy, what nuances to think about as well. Great. Well, thank you so much for covering all of that. So now I'd really like to switch gears, unless Hannah, you have anything that you'd like to add, since let's come back to you.
I guess just one thing I would add is that now that you, the listener, have all these tools in your back pocket, I do think it's important to remember what both Dr. Shellhaas and Betsy said at the beginning, which is that most kids don't experience epilepsy. So only about half of babies with HIE have seizures during the newborn period. And we don't know exactly, but probably somewhere around 1 in 5, as Dr. Shellhaas said, go on to experience epilepsy later. We think the kids that never had seizures in the newborn period are at quite a bit lower risk. And in some studies, none of them go on to have epilepsy. So I want families to not be worried every moment of the day. It can happen. It's important to be prepared, but hopefully your child will not experience epilepsy. And then the other important thing that we're learning is that these severe epilepsy types, like infantile spasms, they come along with severe brain injuries. So most of you as parents will know if that's the case. There was injury to the deep structures of the brain. The child has other manifestations. That EEG was very abnormal for many days, or there were seizures for many days. The exam isn't normal when the child goes home. Those are signs that the child is at higher risk for infantile spasms. Again, the kids that sail through, the EEG looks good. The MRI shows no injury or just mild injury. Those are the kids that we're more hopeful that they will not develop infantile spasms.
Yeah, that's really helpful. I keep using the words context and nuance a lot lately. And that is exactly it, is, we want to empower families with information, but have the context to understand, to keep that worry in check. Like I talk about my personal experience of the epilepsy box was like tucked away in the back, like it was big the first year. And then after year, it tucked back. And again, it's like, it is what it is, if things happen, they happen, but, making sure that it is manageable and you're understanding and really kind of feeling that, your individual child's story, with that as well. Thank you for bringing that up. That's so important. All right. I'd like to switch gears now and talk a little bit about research, and especially with the NSR project, and why, kind of talk about why it was started and, kind of the key findings that have happened. Let's start there.
Sure. So NSR stands for Neonatal Seizure Registry. And we actually started back in around 2012, 2013. And, neonatal seizures are one of the most common issues that we see in the nursery as neurologists. But on the whole, they're fairly rare and too hard to study for just one center, even a big center. And so we got together several colleagues, initially from 7 centers, and then now expanded to 9 centers, to really ask questions that we thought that we as a group could answer related to seizures in newborns. And one important question that we along with others have answered is the most common cause of seizures in newborns is hypoxic ischemic encephalopathy. And that's something we knew, for many years now, and something that we confirmed even after hypothermia treatment, which we know lowers the risk of seizures. It is still the most common cause of seizures in newborns. So something really important to focus on. So we've had several phases of the neonatal seizure registry. Initially, just observing, what are the causes of seizures, who's more likely to get seizures, what are the common treatments within our centers, and then that really important question of how long do the different centers maintain those seizure meds. And we found that our centers were so different in how we approached. We all were the same with phenobarbital at the beginning, but then as we got towards baby discharge, people took different approaches of how long to continue those medicines. And that formed the foundation for the second phase of our study, which was to use that natural variability to understand, well, if we follow these kids for 2 years, the kids that came off medicine, was that safe? Were they more likely to have developmental issues, or were they more likely to have epilepsy? And what we found was no, there was really no difference in the children, and we accounted for all kinds of things like how severe the seizures were and what their clinical patterns looked like. And again, those kids who had the provoked seizures early on, they were safe to come off medicines. Some of them developed epilepsy, but it was really no different if they'd come off medicines or they stayed on medicines. And in fact, some of the most severely affected kids that had developed epilepsy or unprovoked seizures in the first few months after birth, they were the ones who stayed on phenobarbital. So that phenobarbital didn't seem to really prevent them from developing epilepsy.
Yeah. And I think one of the exciting pieces about NSR is, we're working across centers, but we're also working with very engaged parents. And we developed some of the questions and the approach that we are taking in conversation with parents that we were, whose children we were looking after, and developed what kinds of questions do we need to ask? What is the most important endpoint? Is it about development? Is it about epilepsy? Is it about quality of life? What things are important? And the answer was they're all important. And so we were able to design a study in collaboration with parents that I think makes the research much more meaningful.
Yeah, this type of collaboration, I mean, we've been Hope for HIE has been a partner since 2019 now with that. And it has been so fulfilling to see this collaboration come together and look at how, this is really changing the dynamic of research and how, we can all come together on this common cause and purpose and work together, to find solutions and to, learn more. It's really just, I'm seeing it in so many other ways out there. And, it's one of those aha moments, I think, that everyone feels, is like, wow, why didn't we do this before? of just research in general, of that collaboration. And it's been so important to see that, develop and be a part of, what these surveys say and how this whole experience impacts families. And we're just so glad to be a part of it. I'm so grateful for that. And I think, is there anything else that you want to kind of cover of what the future of the project is as we move forward with it?
Yeah, so our big task right now is continuing to follow kids. So parents want to know what happens when my child gets to kindergarten. How are they going to do in school? And these are questions, we can answer for some kids who have very severe injuries. But for other kids that seem to be doing well at age 2, we know they may be continuing to be at risk for epilepsy or having issues with learning and development. So we're following these kids until early school age, and we're just in our first year of that study. So another 4 years or so, we'll have some results to share with you. We're also thinking about, how do we get doctors, now that we know it's safe to stop the medicine, especially phenobarbital, how do we get doctors to actually do that? And so we're thinking about ways we can disseminate those results and implement them. Another really important part of our study, which we haven't really touched on, is parent well-being. We know that having a child in the NICU, and especially having a child with seizures, leads parents to have very high rates of anxiety and depression. And those are symptoms that can persist over years. And we're hoping to learn, how to best support parents through that experience, and also how to support them in a way that also helps to optimize their child's development. We know a parent that's super anxious or depressed and disengaged won't have the opportunities to engage with their child in a way that's developmentally enriching. The more we learn about the brain, the more we know that contact with the parents, the exposure to language, the therapies, practicing all those developmental skills, that's really what helps promote brain development. And if a parent's not feeling their best, they can't be there for the child. So this is another really important topic that we're exploring.
Absolutely. Yeah. I mean, and we see it every day, obviously, the far reaching impacts of trauma, because HIE is a traumatic experience for all involved. And, I think when we look at, one of the phrases I've been using lately is that babies can't raise themselves, right? So we have to educate and empower families to feel their best and feel they have the tools to build those relationships. I mean, that's a huge push for us now in particular, is finding these ways of, really, because communication skills are difficult, I think, for everyone, in different ways. And how do you, proactively and positively build relationships when trauma a lot of times can make you in this fight or flight, and we choose to fight, and we can do it in a less combative way, for a better term, and realize that we're all on the same team. This month's theme is Team Hope, and how we can build these wonderful teams together to optimize each child's unique potential. And so when you talk about best ways to engage and and develop with neuroplasticity and all of these wonderful things with brain development, it's absolutely spot on. And we talk about like, what are those supports that families need in the NICU and then post NICU and making sure that they're connected. So obviously we're a patient support organization and try to, always trying to improve our programs and our offerings for our families, and cannot understate the importance of access to mental health resources, peer-to-peer support. I mean, obviously there's a lot of people that find value in it because, you have people that know what you're going through and there's nothing else like shared lived experiences, but it is no supplementation for actual mental health resources and connecting with, therapists that specialize in PTSD or trauma or anxiety, and getting the tools, like we're all working to get our kids the tools to reach their potential. We're kind of in this era of a lot of times putting our own personal needs aside, but you can't be your best and you deserve to feel good too. Parents should feel that they can have the tools to empower them and feel good about parenting, even if it's an unexpected journey that they didn't anticipate being on.
Mm-hmm. And just to highlight that, I know, especially for moms of kids with HIE, they carry a lot of guilt and they feel a lot of culpability. And I'll say, like, time and time and time again, we see this as just bad luck. Something happened during the delivery that was unexpected, but not necessarily anybody's fault, and especially not the mom's fault. And so I want to emphasize that for the moms of kids with HIE, if you're still carrying that feeling of guilt, that's definitely a sign to get help, because really, again, in most circumstances, there's not a definite cause or a reason why it happened, and almost never is it mom's fault that it happened.
Mm-hmm. Absolutely. Yeah, that is the one thing, and I again see it all day, every day, of families sharing how, when they're talking through how they're processing this experience, it's really hard not to say, so my experience, my placenta failed at 37 weeks randomly, I had great prenatal care, I knew, logically that there was nothing that I could have done to change that situation. And I'm thankful that we went in when we did. So, he could be saved and is here today. And, but it is one of those things that, regardless of if you think logically about it or not, that emotional trauma response is like this wild blame. My body failed. How could my body fail? Like, the one thing that I'm supposed to be good at to be a mom is to protect your child. It's like all these things. But yeah, that's why, again, that mental health support with trained, people, especially in trauma, can be just such a lifesaver for people, for sure. I'm so glad that you touched on that. And as we move into like kind of the final chunk of this presentation and discussion, talking about how do we build this provider, patient, and family partnership, and what are some things that, especially, you both, your experiences and how you counsel your families, what advice would you impart on our families of how to build these positive and proactive relationships?
So I think the first thing is, if we don't hear it, we don't know. And your providers want the best for you, and they want to partner with you to do the very best for your child. And sometimes families, for whatever reasons, don't want to share the struggles that they're going through. But if I don't know that a family's struggling, I might not be able to help them as well. Or I might have an idea of, oh, actually, there's this resource that you could tap into. But if I didn't know it, I might not have told you about it. So I think that's one thing. And I think in the era of doing a lot of telehealth, one of the nice things is being able to have a better sense of what a child's home environment is like, and getting a sense of where sometimes the built environment for a child is helpful or not helpful. But sort of having a more personal touch there, I think, is really nice. For families who are able to have, being able to make videos if they're worried about particular events, being able to make lists of questions when you come to a doctor's appointment, so that you make sure, like, even if I get flustered or forget some things, I know I have 3 questions that I need to make sure I've had answered, that's really helpful. I think it's really tricky navigating health systems, particularly in the COVID era. So calling ahead or messaging your providers to say, like, what's the policy? How many parents can come to an appointment? Can I bring my other children since, they don't have school today, that kind of thing, so that you can avoid stress when necessary. And if there's a particular appointment where you're like, I really just need my spouse or my partner or my mom to come with me to this appointment, to call ahead and see if there's an exception to a visitor policy that could be put in place for you. So all of those kinds of things I think are helpful. Knowing, if there are forms or other things that you need your doctor to have to fill out for you, that kind of thing, if you can do it while you're in a visit, is very helpful. And also knowing that the doctor has teammates too, right? We have nurses, we have social workers, we have care navigators. And so sometimes you might spend some time with me, but then you might spend more time even with my colleagues who are also on the team.
That's so helpful. And I know we encourage our families to be when we talk about being proactive, like, especially for our families that are newer to this, and they always ask, like, I have my 3-month, checkup with neurology. What questions should I ask? I don't even know what question. And I remember that personally, acutely, saying, I don't even know what to ask. Like, what am I going for? What are they looking for? But we are encouraging people to talk about, like, those, if I suspect something, what is the best way to get a hold of you, or how do you want me to work this? Is it, a lot of the EMRs and so the electronic medical records, my chart, things like that, you can upload photos, but not necessarily video. So what is there a way? Is email a better way? Some, depending on the provider, again, going through a nurse, going through whoever, after hours, how does this all work? And trying to really be proactive about that, and how would you suggest families kind of talk through that? Because I know there's sensitivities obviously around, you need to have breaks too, and not overusing that lifeline too.
I think there are a bunch of different layers there. One is talking with your primary care provider to say, when do I call you as a pediatrician or primary care versus when I call my specialist? And you can ask the same thing of the neurologist, like, what's a neurology issue versus a primary care issue? When is it I need to call at night or on the weekend or on a holiday versus this can wait until tomorrow or Monday morning, and sort of setting up those kinds of questions ahead of time, I think, is helpful. What constitutes an emergency? And, I would tell a family who's going home from an HIE newborn experience, if you're worried your baby's having a seizure, that's an emergency. I don't care what time it is, you go or you call us, right? Or if you're a family who's dealing with a new epilepsy diagnosis, if you need to give a rescue medicine for the very first time, we are here for you, and you can call us. And we can advise you to call 911 if need be, or if you're really worried, you use your parent instincts and you call 911. Mm-hmm. So some things like that we can set up ahead of time, and I think that's helpful. We actually try to write out some of those things proactively to give to every family so they know what our expectations are, what our capabilities are.
That's really, really helpful. And that's another message that we hope will get out there to the masses. So that way things like that are done for every family upon discharge, and with follow-ups and everything, because that is just so important. And, again, you're kind of set free into the world after you discharge, no monitors, no nurses, it's a whole scary transitional time, especially with HIE diagnosis.
Yeah. I think the other thing to ask your neurologist is which appointments need to be in person, that I need to bring myself and my baby to the hospital, and which don't. Which could be done by telehealth. And particularly when babies are young, we tend to err on the side of wanting to see them in person. We can get a better exam. We want to make sure that they're growing properly. We can measure, how much do they weigh? What's their head, what's their head growth like? And get sort of better eyes as a hands-on exam. So sometimes families, I think, are a little bit confused about why do I have to come in person versus telemedicine? And so if there's a question about that, please don't hesitate to ask. Most of the time, if your provider is saying, I really need you in person, there's a specific reason that they can articulate for you.
Great. All right, Hannah, thoughts about this?
Yeah, I think just one more thing that I'm not sure either of you touched on was, but don't forget to write things down. It seems impossible that you're going to forget, an event that happened one day that was frightening to you, but we all forget the details. And having a notebook or a binder that just, take a couple notes from each visit you have, write down the questions. If your child is on medicines or, has seizures, to write down when those happen and, write down the medicines and doses, again, in a binder, on a calendar. That can be super helpful. And to have that when you come to your visits. So, when your provider ask questions about when was the last seizure, you have that at your fingertips. And yeah, some of us are super good at remembering, others we don't remember. And the providers do want to know. It helps us to know whether we should adjust medications, when we can stop medications, how to best care for your child. So that would be my final piece of advice.
That's great. Thank you. So I think that is, we can have final thoughts, but that is really all the content we wanted to get through for this. And it's a lot. And I so appreciate you both on behalf of all of Hope for HIE for being a part of our medical advisory board and being a part of Team Hope, and all of the incredible work that you do for the, both in research and in clinic, for all the families that you work with. We are unendingly grateful for you.
Thank you so much. It's really an honor to be part of this team, and we're working really hard to try to advance the state of the art and the state of the science. But we also know it's one patient and one family at a time, and so we're grateful to be part of this. And we are also just want to extend the welcome and the warmth to families who are going through a really tough time, that you found a good place to land, that we encourage you to ask your questions, and to seek the support that you need to let your child thrive.
Thank you.
I couldn't have said it any better. So exactly what Renee said.
Wonderful. Well, thank you both, and we'll look forward to the next one. All right. Take care, everyone. Thank you.
Bye.
Thank you for joining us for another episode of Hope for HIE's official podcast, Just Say HIE. If you have a story you'd like to share, be sure to keep in touch. Learn more about the work we do and sign up for our newsletter on our website at hopeforhie.org/justsayhie. We look forward to connecting with you soon, and thanks for listening.